Hello, everyone, and thank you for joining our Advocacy Grand Rounds tonight. My name is Alyssa Lambrecht, and I'm a third-year medical student at Ohio University Heritage College of Osteopathic Medicine, and I'm excited to moderate today's session. Before we get started, I just wanted to take a minute to invite you all to officially join Doctors for America. Being a DFA member means that you're taking the important step of becoming a paying member and your annual dues to help support Doctors for America's organizational sustainability. There are 6 different levels to choose from, and a DFA member will put the link to join in the chat. This session will also be streamed on Facebook Live, and a recording will be available after the session on our YouTube page. We'll provide additional resources and the PowerPoint slides after the session as well. And a few quick reminders is there's no such thing as a stupid question, and feel free to add any questions to the Q&A feature during the meeting, and we will address them towards the end. And now on to today's speakers, and we are thrilled to welcome Dr. Colleen Lane and Dr. Brian Hurley. Dr. Lane is a triple board certified physician in internal medicine, pediatrics, and addiction medicine. She serves as the director of addiction medicine at Corewell Health West in Grand Rapids, Michigan. She previously served as the medical site director at Whitman Walker Health in Washington, D.C., where she began a substance use disorder program catering to the needs of the community. Through her research and public health endeavors, she aims to learn more about the intersection of substance use in patients living with HIV and hepatitis C. Thank you for being here today, Dr. Lane. And Dr. Brian Hurley completed his fellowship in addiction psychiatry at New York University and serves as the medical director of the Division of Substance Abuse Prevention and Control in Los Angeles County Department of Public Health. He also chairs the SafeMed LA Medications for Addiction Treatment Action Team and is the clinical director of the Addiction Starts Here program for the Center for Care Innovations. Additionally, he is the president of the American Society of Addiction Medicine, and through research and community engagement, he supports access to medications for addiction treatment across Los Angeles County. So thank you both for coming today. And without further ado, I'll pass it over to Dr. Lane to begin.
Well, thank you so much for having me. And I just want to second, there are no stupid questions, so please throw them in the chat. I'm going to share my screen. I have got slides to share and probably more information than I've got time to talk. So I'm glad we're going to share the slides. So if you have any questions, please reach out because I am also available via email, which I have added at the end of the slide deck. I don't have any financial disclosures. You can see by my learning objectives, I was very ambitious with what I hope we could cover today. I'm hoping you're going to have lots of questions so we can discuss at the end. But really today, I'm hoping to talk about and review a little bit about where we are currently with the opioid epidemic and specifically with certain demographics, because I think it's really important to talk about who's being most affected today with the overdose crises. And I also wanted to talk about harm reduction and what harm reduction is and how I use it in my daily practice. And then to review what medications we have in our toolbox to treat opioid use disorders, and specifically buprenorphine, because that's really what we're here today to discuss. How can we use buprenorphine to help treat opioid use disorders, and some tips and tricks, especially in this age of fentanyl? How can we get folks started, or how can we induce people onto buprenorphine? And then I wanted to spend just a moment talking about low barrier addiction care. What does a model like that look like, and how can it be successful? So I'm sure a lot of us have heard about kind of this heading or this topic, the epidemic during the pandemic. So the opioid overdose crises is not anything new. You know, we were talking about this and our patients have been living with this reality much before COVID-19, but we really saw the effects of COVID-19 exacerbate the already high levels of folks suffering from accidental drug poisonings. And the nomenclature of overdose deaths has really started to change to drug poisonings. So you might start to see that change in presentations and articles because there's contamination in the illicit drug supply. So a lot of people do not know what they're being exposed to. So it truly is drug poisonings that people are suffering from. And a lot of the drivers to what's going on is that in COVID-19, there was less access to treatment, people were more isolated, people were suffering from greater issues with mental health. And then again, that contamination of the illicit drug supply, really driven chiefly by fentanyl, is what we saw affecting these spikes in overdose deaths. If we drill down to who was being affected, it is our Black and Brown neighbors, and really Native American folks and African American people. So if we look from 2018 to 2020, overdose deaths were increasing among Native American folks, Black people, Latinx individuals, and the rates specifically among African American men have tripled during that time. And currently today, their overdose deaths are now on par with Native American individuals. So in the next slide, you can see that the death rates, which is the blue line there for African Americans, has spiked significantly, and it's now overlapping that gray line, which are Native American individuals. And that has happened over a very short amount of time. And the authors of this study who published this report, when they looked about reasons why this is happening, I took this quote out because I really think it kind of encapsulates the factors about why Black men are disproportionately dying from overdose deaths. And Dr. Hansen said, people who are lower on the social hierarchy tend to be exposed to fentanyl and other highly potent synthetic opioids at disproportionate rates. So people who are lower in the socioeconomic hierarchy are being exposed to more contaminated illicit drug supply than people who are at the higher end of the social hierarchy who can afford less contaminated drugs. That also is being paired with less access to quality healthcare, less access to substance use disorder care, and also being arrested and incarcerated at much higher rates compared to other social demographics. So when we look at kind of where we're going with these overdose crisis, there's a Lancet article that's going to be published, the Opioid Commission, who's projecting that 1.2 million overdose deaths will be suffered in the next decade if we don't change course. And again, that will be mostly suffered by African American individuals and other minority groups. So what can we do as healthcare workers, as other people working in the medical field, and people working with folks living with substance use disorder? So we can change our approach, and I think our focus has started to embrace more of a harm reduction approach as more of the standard of care. And I put some of the quotes or some of the attention that our government agencies have paid to harm reduction, and this was on their website. I think I pulled these last night from SAMHSA and the Department of Health and Human Services, that are commenting specifically on the importance of harm reduction. So SAMHSA is saying that harm reduction is an evidence-based approach. So this is a critical tool to save lives. The Department of Health and Human Services is saying that this is a key strategy to their overdose prevention strategy, and that this is going to keep people alive. The National Harm Reduction Coalition is pointing out that this is not a one-size-fits-all approach. It's a spectrum of strategies. So harm reduction means safer use. It means managed use, might mean abstinence for some people, but it's really truly meeting people who use substances where they are. So what does that look like in practice? If you've got a patient or somebody sitting in front of you, when I'm talking to somebody, it really truly is asking what their goal is. So when somebody is sitting with me in our clinic, we don't require abstinence. We work with anyone who's on the spectrum of readiness to change. For some people, it might just be learning what their options are. For some people, it might be coming to get their hepatitis C tested or treated and cured. For other people, it might be just working on their opioid use disorder. They're not yet ready to cut down or stop methamphetamine use. So it truly is partnering with patients, working to achieve their health goals. It might be talking about safer ways to use substances to lower their comorbidities, lower their risk of mortality, connecting them with community resources for things like safe supplies, safe works, treating infections, connecting them with resources, or prescribing PrEP, which is the medications that prevent the transmission for HIV, again, curing hepatitis C. What this does is give patients the opportunity to access care and keep them alive. So what are evidence for next steps with harm reduction? So advocacy groups are really pointing out that successful strategies have been implemented with safe consumption sites or overdose prevention sites, which are tools that are being used in Europe, Canada, and Australia, and also legally sanctioned in some spots here in the United States. The first state, Rhode Island, authorized a supervised consumption site in 2021. And then later that year, there was 2 sites opened in New York City. And what the data is showing from those sites is that at least the 2 sites in New York, they had about 2,300 participants and more than 55,000 visits. And this was in 2021. And they had 700 overdose events and 0 deaths in those facilities. So what about medications? We've got those tools in our toolbox to work with. The medications that we have are methadone, naltrexone, and buprenorphine. Specifically, we're talking about for opioid use disorder. So these medications are all medications that interact with the opioid receptor in your brain or in the central nervous system. And just as also a reminder or a review of nomenclature, MOUD is medications for opioid use disorder. There's a little bit of an older nomenclature that you might see or hear. MAT is medication assisted treatment, but they both kind of refer to the same or similar thing. Methadone is a full opioid agonist. It sits in that opioid receptor, it binds to it, and it activates it fully. And we'll go into a little bit more detail in a couple slides. Buprenorphine is called a partial opioid agonist, kind of imperfectly fits in that receptor. It binds that receptor, actually very tightly binds it with a high affinity or a high attraction, but it doesn't turn that receptor on all the way. And then naltrexone kind of blocks that receptor, sits on it like a cap, and it does not turn that receptor on. As a reminder, opioid receptors, there's different categories. We're talking chiefly about the mu opioid receptor. And when that receptor is activated, it has several different effects. Pain relief or analgesia, but it also can cause things like slowing down your breathing, cause you to feel sleepy or sedated, euphoric or high, can also cause physical dependency. So if you don't have opioids in your system and you're physically dependent, that's when you can experience withdrawal. So naltrexone is that opioid receptor antagonist. It is blocking that receptor. It is, again, not turning it on. It is not interacting with the receptor, not causing those effects. It is not treating withdrawal. So that's actually something very key. If someone is opioid dependent, so someone has been using opioids daily, and you give them naltrexone, it will actually cause them to go into withdrawal. So this is a medication that we have to be careful in what type of patient or what patient might be a good choice to use this medication in. It's someone who has not had opioids or is not opioid dependent. It might be someone who has been abstinent for a period of time, might be nervous or afraid they could be exposed to opioids again. For example, someone who's using stimulants and maybe afraid that they might be accidentally exposed to contaminated fentanyl, for example, or someone who wants like a safety net, kind of an assurance that if they were exposed to an opioid, they were protected from an accidental overdose. Couple of different options, a daily pill or a once monthly injection. So we have those choices for patients. Methadone is a full opioid receptor agonist. So it sits in that opioid receptor and it fully activates it. It acts very similarly or the same way that other opioids, heroin, fentanyl, prescription opioids would interact with that receptor. So it's very good at controlling cravings, withdrawal, but it can also lead to dependency and tolerance. Methadone's long acting, so you can take it once a day, or the effects can also last for a couple of days. It is a safe medication, but if you take it in combination with other things like alcohol, benzodiazepines, or other illicit opioids or other opioids, it can lead to an overdose because of the combination of effects of those medications. There's also certain cardiac effects, so something called a prolonged QT, especially when used with other medications, certain medications. So it needs to be monitored closely. And for treatment for opioid use disorder, it has to be dispensed at an opioid treatment program. So otherwise known as a methadone clinic. These clinics have very, very strict federal oversight and regulations. Patients oftentimes need to go daily to get their medication dispensed, typically for about a year, in order to really demonstrate consistency with their dosing, in order to find kind of a safe dose for their body. And then once they're able to have that consistency, they can have take-home doses. Now, during COVID, some of those rules were a little bit relaxed, and people were able to get take-home dosing more quickly and for longer period of time. And there is some conversation happening about hopefully kind of keeping those COVID relaxation rules for longer. Now, buprenorphine. This is that partial opioid agonist. So it works or sits in that mu opioid receptor, but it does not activate it fully. It is a impartial fit or imperfect fit, but it's got a very, very high affinity, strong attraction for that receptor, stronger than most other opiates. It also has a slow disassociation from the receptor, so it works for a long time, but it creates much less euphoria, less sedation, less respiratory depression because of that partial effect. So it's safer than a full opioid agonist. So much less risk of a accidental overdose or an overdose. Some of the common brands that you might have heard of, probably the most common is Suboxone, but Subsolve, Subutex, those are all sublingual formulations that dissolve under the tongue or in the cheek. There's also long-acting injectable forms, one of which that was just FDA approved, Brixadi. Again, it is sublingually applied. It actually has very poor bioavailability if you swallow it because of first pass metabolism, meaning if I swallow it, my liver detoxifies or metabolizes the majority of it away, and I don't get the effect of the medication. So it has to be absorbed sublingually, which is actually a little bit tricky for most patients to kind of get used to if it's the first time that they've tried the medication. So it takes a few kind of sessions to kind of counsel patients on how to take it correctly and get the full effect. It can take a couple of minutes for the medication to fully dissolve, and the taste is not great. So I usually warn patients if they haven't tried it before. A lot of people have tried it from friends or family before, so they're not shocked by the taste. but it tastes like a bitter orange peel, or kind of, depending on the brand, it also tastes like a bitter mint. And depending on how dry your mouth is, it can take, up to 15 minutes for it to dissolve. You can't take a drink or eat something, because that again will kind of have you swallow the medication and go into the stomach, and then you'll have that first pass metabolism. Also important to note, you can't vape or smoke while the medication is in your mouth, because that will also block the sublingual absorption. This is the long-acting injectable that is currently available on the market. The brand for this is Sublocade. It is a once monthly injection, so it works really well for a lot of patients. Usually takes a couple of months for patients to feel like they are fully saturated with the medication. But because it's got that long-acting, it's a subcutaneous injection, it slowly is absorbed, and it's much more stable than the sublingual, so people feel like it's more consistent. It also avoids needing to go to the pharmacy, avoids forgetting the medication. Also very helpful for patients who can't keep their medication safe, for example, unhoused folks. There is this phenomenon of precipitated withdrawal. So because of that high affinity for the opioid receptor, buprenorphine will kind of push away any other full opioid agonist. If I have it in my system, if I have it in my body, and I take a full dose or a therapeutic dose of buprenorphine, and I have a full opioid agonist in my body, my opioid receptor will give up that full agonist in order to hold on or accept buprenorphine instead. And you can see on this graph that opioid effect, it kind of feels like being in a car on the highway going at 100 miles an hour and then slamming on the brake to 60 miles an hour. You feel the difference. You can feel that withdrawal difference happening, this area under the curve. The goal with transition is for it to be much more subtle.
Dr. Lane, so the slides also have been frozen, but we did share that we'll share the slides afterwards.
Oh no.
But then also maybe we can get into induction closer to like the end of the presentation
Yeah.
in a format if you want to wrap up whatever you want to discuss in the last few minutes.
Yeah, sure. So we can, if we want to share or say the induction strategies for the Q&A, that's basically the last slides I had, but they are low dose inductions, micro inductions, macro, and then something called the Bernese method, which was actually published in 2016. I'm actually interested to see what Dr. Hurley thinks about this. It is not as, I would say, commonly used, or not in common practice, but the Bernese method is a slow kind of cross titration where you have folks continue their full opioid agonist while you are slowly increasing or up titrating their buprenorphine. So the thought is that you are having that transition of the opioid receptors from the full opioid agonist to the buprenorphine, so it's much more subtle, so that there's less of that withdrawal experience. So we often will do this with folks who are transitioning from methadone clinic to buprenorphine, but in the age of fentanyl, it has also been a strategy for people who have had a precipitated withdrawal and are have a lot of anxiety around trying to induce on buprenorphine again. Yeah, I'm going to stop sharing so we can make sure we get enough time for questions.
All right, cool. So, hey everybody, Brian Hurley. I am an addiction physician. I will go ahead and share my screen. Just give me 1 second while Zoom gets its acting together. While I am getting my act together. I should disclose I don't have any financial conflicts of interest. I am the president of the American Society of Addiction Medicine. ASAM has textbooks and ASAM criteria, so I don't have a financial conflict of interest, but it is like, you know, it is not neutral with respect to ASAM, and should be coming through live right now. All right, cool. So yeah, I might be a bit biased towards ASAM. With that is a conflict. I'm not going to repeat what Dr. Lane mentioned. We are in the worst overdose crisis in American history. We are more overdoses than ever in history as a country. And it is driven by far and away by fentanyl. Here locally in Los Angeles, the two biggest drivers of overdose are fentanyl and methamphetamine. That is not uncommon in other parts of the United States. We are seeing these synthetics, right? Not necessarily the plant cocaine or plant heroin, but the synthetic fentanyl and the synthetic methamphetamine that is really driving overdose deaths here. This is just a quick picture looking at the comparative potency of heroin, fentanyl, carfentanil, and the carfentanil could be alpha fentanyl, sufentanil, but there's ever more increasingly potent fentanyls in the drug supply. 6% of people with addiction receive treatment. And I sometimes get amassed, like, well, why don't we just put people who use drugs and have them go to treatment? And that fails 94% of the time, right? What's the number one reason? And this is, I regret, interactive. What's the number one reason why people with addiction don't get treatment? Does anyone know? And this comes from the National Survey in Drugs and Health, so it's a household survey, which means that it does not sample unhoused individuals nearly as often as it should. But does anyone know what's the number one reason why people with substance use disorders don't get treatment?
They don't know it exists.
Yeah, so maybe they're not offered. That is a reason. It is not the number one reason.
Shame, embarrassment.
So a lot of people think it's stigma, and stigma plays into it. But the number one reason why people don't get treatment is that they don't want treatment. We have an addiction treatment industry that is siloed from the rest of healthcare and is built around assumptions of abstinence. We're essentially, and I work in addiction treatment, we're essentially selling a product that the people that need it most don't really want. And so it will not work for the addiction treatment system to simply expand capacity. It's not a supply issue. I mean, there are access issues. I'm not saying there aren't access issues. For sure, there's access issues. But the biggest driver of the treatment gap is lack of demand, because addiction treatment is typically selling something, right? Specialty addiction treatment services, selling something that most people with addiction are not at this moment particularly interested in. So it is a failing proposition to try to get people to go to treatment. We are much more successful when we bring treatment to people. So I've stopped having conversations with people like, are you ready to commit to full sustained abstinence from this point forever forward? And started having conversations with people, are you interested in a medication that can help you feel better? I'm not saying you have to stop using. I'm not saying you even have to like commit to change. Like, if somebody does say, oh, you know what, I've thought about it, I really need to change my life. Great, let's capitalize on it. We have a treatment program for that. But we are not going to get our way out of this overdose crisis by trying to double the number of treatment slots and get everyone into treatment. We have to bring treatment to where people are. Okay. A couple social media messages that I work on locally, like, you never know by looking, protect yourself, never use drugs alone, have naloxone on hand. I sometimes get asked by parents, why don't you just tell people not to use drugs? And my answer is because that has no effect on whether people use drugs or not. But if you tell people things like, don't use alone, be aware of the drug supply, those are the things that actually empower people to take agency over their health behaviors. This is what generic naloxone looks like. It's a nasal spray. Because no one needs to die of an overdose. So lesson one, everyone gets Narcan. Everybody gets Narcan. Everybody gets Narcan. Like, use drugs, you get Narcan. You don't use drugs, you get Narcan. Everyone should get Narcan. And we should be using health insurance to pay for it, because there are grant-funded naloxone programs for people with structural barriers to accessing healthcare. If you're seeing a patient, that person does not have a barrier in seeing you. so because they're seeing you, right? So don't hesitate to issue prescriptions and use our pharmacy apparatus. I mean, hand out Narcan too, but don't just hand it, like, prescribe Narcan and use our healthcare apparatus the way that we could. We are ethically bound to provide services that give patients the best chance of success. That means using treatment based on evidence. So you might hear things like, I don't believe in medications for addiction treatment. And then I would remind you, metformin works despite faith. So does insulin, so does, propranolol, or, whatever kids are using these days, an antihypertensive. I'm a psychiatrist, so I know none of these things, but engaging patients with evidence-based choices is absolutely essential. There's a really elegant study that was done looking at the go, no-go test. It's an implicit bias test, and found that language really matters, right? So we stop saying things like medication-assisted treatment or overdose or addict or alcoholic. We start saying things like person that use substances, pharmacotherapy. Dr. Lane made the point about accidental drug poisoning. But if we really do want to shape the way that people with addiction get treated with dignity and respect, changing the language you use is a really important part of that. So stop saying the word clean and sober, because if somebody's still using, what does that mean for them, right? It's a pejorative term. So avoid labeling our patients. Oftentimes we need training in a conscious bias. I have a couple training resources I'll put in the slide deck, such as the NIDA Language Matters website that has like trainings and just fact sheets on language to avoid. So the US Surgeon General has this report, Facing Addiction in America. It's long and there's a lot of language in there, but there's this line that I really like, which is integrating substance use services results in better outcomes. Here's how I visualize it. We have like the addiction treatment system and the medical hospital systems and primary care clinics. And what's interesting is what we're talking about today, medications for addiction treatment, exists in this nether region. Like no one really owns it. So like addiction treatment systems do, but really don't. Primary care could, but doesn't. Medical hospitals can. If you talk to like my California Bridge colleagues, or Bridge to Treatment colleagues, as I think it's increasingly called, but no one really like owns medications for addiction treatment or medications for opioid use disorder or addiction pharmacotherapy, or pick your term of choice. And then there's like mental health clinics and housing services. And I just want to point out, like in the addiction treatment industry, most addiction treatment programs are run by psychosocial clinicians that don't prescribe. So like these like addiction pharmacotherapy really exists as its own space. Really, almost half of people with substance use disorders have co-occurring mental illnesses. Like the future is that addiction treatment offers meds, and medical hospitals offer medications and counseling support and referrals, as does primary care, as does medical clinics. And rather than thinking about addiction treatment as this specialty service that exists as its own industry, we're thinking about addiction treatment as an integrated service that's just part of what we do in the rest of healthcare. I am not saying every hospital has to have a residential treatment program built on the back of it. I'm saying that a medical hospital can do meds, counseling, and referrals the same way that we do meds, counseling, and referrals for diabetes or hypertension or other medical conditions, and that connect people to ongoing care. And that ongoing care could be an addiction treatment program for people that want that. It can also be in primary care, right? There's a number of places where people can sustain gains. What are the core components of addiction? Meds, counseling, support. How do you treat depression? Meds, counseling, support. How do you treat diabetes? Meds, diet, exercise, right? Like the triad of behavioral medicine is not so unique in addiction. The reason that addiction is so different is because of stigma, not because there's anything medically complicated about it. Here's a list of psychotherapies. They all can be helpful. And I think we already went through the pharmacology of methadone, buprenorphine, and naltrexone, but I do want to emphasize that the biggest single thing we can do with meds, counseling, and support is the meds for opioid addiction. It reduces mortality by over 4-fold. It improves treatment retention. It increases the likelihood that someone might stop using drugs, although we would still do it even if it didn't, because it keeps people alive. No one recovers if they're dead. So this leads to the definition of a med-first model, which is people with opioid use disorder receive pharmacotherapy as quickly as possible upon diagnosis, even if you've not completed a full conflict of interest alert, comprehensive psychosocial assessment, such as the ASAM criteria assessment. You do not have to do all of that to treat somebody with medications for opioid use disorder. Now, it's useful to get that at some point, but you don't need to like gatekeep medication services for full psychosocial assessments. That we deliver meds as long as it helps. So it isn't like, well, we're a 2-week med program, or we're not program centered, we're patient centered, right? That you deliver meds as long as it makes the patients better. And you always offer psychosocial treatment, but you never make it a condition. The meds are never conditional upon getting psychosocial treatment. We really only discontinue the meds if it's making the patient worse. Med first is not med only. It just means that the medication is a foundation of the treatment, but other things get built on as patient readiness. I don't know that we're going to get into the dosing stuff, but I do want to make the point of Every study done on medications for opioid use disorder shows the same thing. The longer, the better. Does that mean every patient needs to stay on buprenorphine or methadone or other medications as long as they live? That is a complicated question, to which I would say, I don't want anyone to get meds for any longer than they need it. And some patients need it their whole lives. So like, some patients need it their whole life, and that's just part of the deal, right? But that you would do a very individualized assessment for when a patient is ready to come off and when they've acquired other skills and have attained other psychosocial stability to be able to sustain abstinence if that is their goal. If somebody's continuing to use, I'm probably just going to continue buprenorphine or other medications for addiction treatment as long as it makes sense. I can't help but throw in, it's not just buprenorphine. We've got meds for alcohol use disorder, and this is a great study, Project Combine, oral naltrexone, that showed reduced drinking with meds alone. Like this, there was like people that meds and counseling, and people with meds alone. And interestingly, meds plus counseling did not have any additive benefit. They're all within the same, confidence interval, right? So meds work, counseling works, and the combination works. Interestingly, it didn't seem to work any better in Project Combine. And when you take naltrexone at long-acting injection for alcohol use disorder, heavy drinking days go down. If you use tobacco use disorder treatments, smoking goes down. If you use off-label meds for methamphetamine use disorder, because we do have off-label meds for methamphetamine use disorder, methamphetamine use goes down, right? So I think of like addiction as no longer being this like you just stick with one thing. Now, why are we here? One of the big reasons we're here is because of the X waiver. Show of hands, how many of you have your X waiver?
2 people in the chat.
Tracy and Stephen, trick question. None of us have our X waiver anymore. It's been removed. The X waiver has been eliminated. It doesn't exist. So I'm glad I did the training, 8 hours. It was great. I trained like 1,000 people. So like I've done many of these trainings. I'm glad I did it, but it is no longer required. That registration has been like literally there is no place to look it up. We've been reissued our DEA registrations. None of them have X waivers on it anymore. So one of the big reasons that we're here is, hey, any of us that have a standard DEA registration with Schedule 3 can prescribe buprenorphine for the indication of opioid use disorder. No extra training, no extra X waivers required. And so really, I think the task is now helping support our physician and medical colleagues that have DEA registrations to treat opioid use disorder with buprenorphine, consider other medications for treating addiction, and take on points. Everyone gets naloxone, language matters. The lack of demand is a bigger driver of the lack of supply. 95, and you might say, wait, isn't it 96.7 of 94%? And I would say yes, but 95% is an easier number. 95% of people don't get specialty SUD treatment because they're not interested in treatment as usual. We have to bring treatment to people. That means meds, counseling, support where people are. Don't assume the goal of abstinence initially. Addiction medications are the standard of care for opioid use disorder as quickly as possible without unnecessary contingencies. Conflict of interest alert. Come to the ASAM meeting, Dallas 2024. Come to the California Society of Addiction Medicine meeting, San Diego, September 2023, and the addiction psychiatry meeting coming up. I have a huge conflict of interest in promoting those, but you should still go. It's good. And with that, I will go ahead and stop my screen and we can get to some Q&A.
Sounds great. Thank you both for providing like such unique perspectives. And I feel like, at least as a medical student, I learned a lot of different ways of thinking that I feel like we don't get in our curriculum. So I think it's important to remind people of all stages of training about some of these topics. So I don't recognize a lot of the names in the chat. So if anyone has questions, please feel free to put them in the chat. We can talk more about induction or different levels of, what we want to talk about depending on who's here and making up the audience. But if no questions are necessarily coming in, maybe we can talk a little bit about the principle of induction and maybe why there's a misunderstanding among providers about what that means and how to do it. Because I feel like that's probably something that, at least as trainees, we don't hear anything about and would be nice to review.
Yeah. I can start talking about it if there's no question. So I think, and I don't know what Dr. Hurley's experience is, but the majority of patients that we see in our clinic are not buprenorphine naive. So most people have tried buprenorphine from a friend or a family member in the past. And it's interesting because their experience will highly predict what they're expecting their experience to be when they're coming and sitting in front of you. And unfortunately, if they've had a bad experience with buprenorphine in the past, it's an uphill battle to get them to try buprenorphine again. In the age of fentanyl, it's very tricky to start folks on buprenorphine because fentanyl has a very small therapeutic window. So fentanyl works to make you feel euphoric for a short amount of time, and then you start feeling withdrawal pretty quickly, but it's still on your receptor. It's very highly lipophilic, so it's kind of hanging on your receptor for a lot longer than heroin traditionally hung on. So you could pretty confidently advise somebody with heroin that you could start buprenorphine about 24 to 36 hours after their last dose of heroin. With fentanyl, it's a lot trickier. So some of the approaches that we've tried is kind of slowly starting buprenorphine little by little. So as the fentanyl is coming out of their system, we're kind of shifting up the buprenorphine as the fentanyl is coming out. That's kind of one approach. That's a low dose induction. A macro induction is if somebody's had a drug poisoning event and had typically Narcan, all of their opioid receptors have then actually been evacuated of their full agonist. So that's an opportunity to start a full therapeutic dose of buprenorphine, typically in the emergency department. So they can go ahead and get a full dose and transition directly into buprenorphine right away. Another kind of method that I was talking about was that Bernese method, where you actually talk about the risk and the benefit of continuing their full opioid agonist while you are doing the low dose buprenorphine, because we're taking advantage of that unique pharmacology of the buprenorphine having the high affinity for your opioid receptor. So as I'm introducing buprenorphine at higher and higher doses, I'm kind of shifting over your percent concentration of buprenorphine while keeping the benefit of you being therapeutic on your full opioid agonist at the same time. And then more often, we're also offering a rapid induction onto injectable subcutaneous buprenorphine, which has kind of this almost self-titration low induction. So for some people, there's just this anticipatory anxiety of needing to dose themselves, especially if they've had a bad effect with buprenorphine in the past. It's a lot to ask somebody to, give themselves a dose every couple of hours and, cross our fingers that it goes well. If you give them this dose of long-acting injectable, once it's in your body, it's going to keep kind of self-titrating up, and it's a much more subtle increase than the sublingual dose, which is a pretty significant bolus when you look at the pharmacology.
So I think you had asked earlier, like, what do you think about the Bernese methods? So, just a couple principles. So I've stopped using the word induction because it makes buprenorphine sound like birth or something. Like I started using the word like start buprenorphine, right? How do you start buprenorphine? And the reality is probably 75% of the time, I'm like, hey, do you know how to use buprenorphine? Yeah, I've taken it before. What's your dose? This is your dose. Okay. You got to start it? Yeah, I'm good. Okay, cool. You know what I mean? Like I just want to emphasize, there's a subset of time that patients have trouble. A lot of patients kind of know what they're doing. A lot of people are exposed to it. So but what do you do if the patient's truly sort of naive to buprenorphine? Oh, this medicine doesn't work, it precipitates withdrawal. Or let's say I'm allergic, which means for the most part, precipitated withdrawal. So a couple things. So Andrew Herring has a bunch of stuff in the emergency room where they basically give people 8 milligrams every hour up to 32 milligrams, right? Like, or until they're kind of no longer in withdrawal. So it's this high dose rapid initiation. And what happens if people go into withdrawal? Well, Zofran for nausea, acetaminophen for headache, benzos for agitation. You know what I mean? Like, because it's the ER, right? You just sort of treat with meds. So in an ER setting, I actually think, particularly where like time is of the essence, they're typically not doing like slower initiations. Usually in those settings, it's like get the blood level up as fast as possible, get somebody through. And I remember I was coaching a colleague of mine who had a patient, and like the patient was really upset for a few hours, and then like finally, like kind of the agonist effect of buprenorphine work. But it is absolutely true that for people transitioning off of fentanyl, particularly high dose fentanyls, it can be very uncomfortable for them to get started. And so it isn't necessarily that buprenorphine doesn't work for them. It's the how do you get them onto it effectively. And so some people that are terrified of withdrawal, it's a negotiation. Like we can go low dose, you can stay on your fentanyl, or we can do microdosing. Microdosing, like quartering a 2 milligram film. So you end up with like 0.5 milligram twice a day, then 1 milligram twice a day. You sort of slowly go up until eventually, and it can be a more comfortable transition. That requires a lot of psychosocial stability. I've not had patients experiencing homelessness that are in sort of in psychosocial chaos and really be able to adhere to low dose. But for people who like can get, like they have a regular supply, they have a system, I think that it can work well. And then oftentimes it's I don't think I've ever had an initiation work exactly the same way twice. For each person, it's kind of an individualized system in negotiation. And for people that I know that are using fentanyl heavily, either we try to arrange for an admission where they can get initiated rapidly with a lot of support, or they have my cell phone. We do a lot of like hand holding while they're wherever they are, whether it's a home or an encampment or wherever they are. And the last thing is the biggest error that I see with kind of buprenorphine and fentanyl is when a patient really does need a higher dose and isn't getting it, right? So like I do tell patients, like if you're tolerating, continue to take, like listen to your body, dose yourself, recognize this is going to be uncomfortable, but on the other side, if you can get the dose of buprenorphine high enough, most patients do okay. We sort of mentioned earlier, so ASAM is supporting legislation, the Modernizing Opiate Treatment Access Act, which would create a pathway for board certified addiction physicians to dose people with methadone. So like, keep in mind, at the end of the day, there are other agonists that we could use if buprenorphine is untenable, but we've got more than just the standard buprenorphine dose. And you know, what's the best dose? The one the patient takes, right? And it's this kind of individualized assessment. And I don't think I think the fretting over will this work or not is ultimately counterproductive. If you're partnered with a patient, you can usually get through precipitated withdrawal. It's just an issue of communicating and figuring out a plan.
Thank you. We do have a question in the chat, and if Dr. Martin, this doesn't encompass it, we can follow up after. But can you talk a little bit about maybe like how in your own clinic and community you can try to increase patients wanting to get treatment? Because he brought up an issue of like how patients who don't want treatment, like what we can do on an individual patient level to try to increase that desire.
Yeah, I just think making it clear that addiction medications are the standard of care, that it's not actually that complicated, and creating widespread organizational capacity. I work on doing a lot of coaching, and I think like 80% of the effort is like getting the security staff, front desk staff, clinic administrators, billing team, like sort of see this as relevant and important. And yes, there are like, what is the right starting dose and how do you, like, that's not irrelevant, but the actual dosing is like a trivial part of it. And a lot of it is like working with organizations and doing organizational capacity. So Stephen, I could point you towards like a lot of the Boston University stuff on integrated MOUD treatment, the Summit trial out here in LA. There's a RAND implementation toolkit for co-occurring disorder. I mean, there's a bunch of sort of toolkits on this, but I really do think it's an issue of champions working in local settings, really operationalizing treatments and helping everyone just recognize that addiction is just another a medical illness that we all have the tools to treat. So how can we address this quickly at scale? Universal access as quickly as we can.
Yeah, hi, this is Steve Martin. I'm sorry, I was unmuted. Brian, I don't know if you can hear me. Yeah,
Perfectly.
very good. So Brian, I'm actually on the quality committee at ASAM, so I appreciate all your work very much. I really do ask this. I don't think any of that's going to happen. And if you actually look at the uptake of buprenorphine in the last year, it's 5,000 new starts over baseline, which is not even coming close to what we need at scale. So I'm asking this in a very deep way. I've worked at the U, and so I know all the sort of ways things go back and forth, but forget about it. It's not happening. And I don't see it ever coming into primary care at scale because primary care is so dreadfully broken. So I don't know honestly don't know an alternative, and so I'm asking with that
I will say
humility.
there's one thing that we've done here in LA, and there was a talk at the ASAM conference about this a couple of years ago on telehealth, right? So if telehealth is the only thing that's tricky about it is it sort of relies on widespread awareness. But there are sort of now a number of kind of remote MOUD delivery options where if you can get it saturated, can help. So in LA, we launched a MAT line that will actually like deliver medications to, or by say deliver, get prescriptions to medications to community pharmacies that can arrange delivery, working with a team of local substance use navigators. It's not terribly inexpensive, but it's publicly funded, and it's something that you could get at scale that doesn't rely on primary care. But all of the examples of that are relatively small scale at this point, sort of county-based and local community-based. None of them are sort of national.
I will say what we are doing. So I came from an HIV background. So when I started back here in Michigan, I brought the model of same day start, which is also called red carpet HIV. So same day MOUD nurse-led model to our addiction clinic. And since starting that in the last year and a half, we've seen 600 walk-in patients for same day start medication access. In order to do that, we also had to think about creating capacity for those high-risk patients. So we truly started to figure out how to get our hospital system to see addiction as a specialty service and think about it like we think about other specialties, right? So the highest need patients get seen by a specialist, get stabilized with a medication regimen, and then with the idea that they will eventually get transitioned back to primary care. So we have the benefit of having some value-based clinic models in our primary care practices. And so we are transitioning our stable patients to value-based primary care. It's taken us a year and a half of education and working with the primary care leaders, and we're doing it extremely slowly. So transitioning like 1 or 2 with a promise of a maximum of 5 stable patients to value-based clinics because they have lots of wraparound services and support. So that's how we are starting to create capacity and confidence in primary care.
Catherine talks about buprenorphine abuse. So a lot of the evidence on people say purchasing buprenorphine on the street and using it outside of a prescription is people using buprenorphine to self-treat withdrawal. The actual people sort of finding a euphoric effect and choosing buprenorphine, other opioids, is pretty rare. For most people, buprenorphine is not their opioid choice for an intoxication effect. Most people are sort of self-treating. So it speaks to if we had more universal access to buprenorphine and other medications for opioid use disorder, I think we would just see significant drops in people sort of using buprenorphine illicitly because they get it as prescribed. Dr. Lane, do you have I'm curious what you think.
Yeah, Canada actually did a really good study on diversion. So diversion is medications prescribed to patients ending up in hands of people other than that patient. And so they looked at medications for opioid use disorder diversion specifically, and the vast majority of those medications ended up with friends or family who didn't have access to treatment, who were sick. So again, it is those medications not for euphoria or for recreation. It is because there's a lack of access for treatment.
There's no last question. Is there any last thoughts, statements that we didn't cover that you want people to take away from this with?
I think, take homes are, harm reduction really is starting to become the standard of care. It's a little bit of a buzzword, but really what this means is partnering with patients, figuring out what their health goals are, and really pivoting from a place where we used to be approach of abstinence-based substance use care, which was not a welcoming place, and the evidence did not support that being a successful approach, and really now making harm reduction and goal-oriented care our standard practice so we can invite more patients into care and save more lives.
everyone gets Narcan, universal access to medications for addiction treatment. And I think really any treatment we have with somebody is built on the foundation. So whether it's a treatment understanding that people are going to continue to use, whether it's house-based treatment, focusing on a relationship and on our engagement of patients is really fundamental. So I do want to appreciate that. I'm going to put a link to oh, I don't have a way of doing that. So never mind. I was going to put a link in the chat, but I think I can only do it to those panelists, to the slide deck. And then ASAM just published clinical guidance document on treating with buprenorphine and era fentanyl that I think covers, I don't know that we got into all of the different strategies that Dr. Lane alluded to. So I would, conflict of interest alert, would promote that. And I do want to thank Dr. Martin for your leadership on ASAM and quality improvement. And I think how do we do this at scale across as a public health intervention is worthy of more conversation than we have time for on this webinar.
For your time and for this thought-provoking discussion. Definitely a lot of topics, and like you said, a lot of complex issues that are going to take more time. But Doctors for America, we have a substance use disorder subcommittee where we're trying to work on a lot of these issues through advocacy. So that's always an avenue to help get more involved. I assume the American Society of Addiction Medicine also has ways to get involved. But thank you again for coming today. There will be a link put in the chat that will just be a survey about the event tonight, what you'd like to see in the future, different event topics that you might like to see. And again, thank you for all the work that you do with your patients and with advocacy, and just taking the time to be here tonight says a lot about the work that you do and want to do in the future. And we will be sending out further the slides and more resources after this as well. And if there's not any last minute thoughts, we thank everyone again for joining this evening, and have a good night.